Thanks for joining us today. We are joined by Victoria Greene, who's going to present for us on oral and systemic health, the power of preventative medicine. Before I turn it over to Victoria, just a few housekeeping items. Today is a StillHealthy seminar. Make sure you go to your mycigna.com, give yourself credit for today's event. You have 41 days left until the StillHealthy deadline, so make sure you're getting those requirements in. This is a recorded event. We will post it on the StillHealthy YouTube and Google sites once it's completed. So if you're not able to attend the whole session, you can check back there and finish what you weren't able to see. So with that, I'll be monitoring the chat box. So if you have any questions, feel free to put those in there as we go through the seminar, and then we'll reserve a few minutes towards the end to answer those questions. So Victoria, whenever you're ready, take it away.
My name is Victoria Greene. I'm part of the faculty here at ASDO. So in that role, I get to work with our dental students for all 4 years of their education. And I also teach dental hygiene students through the University of Pittsburgh. And in that capacity, I teach a health promotion course. So that's a 15-week class that I'm in no way trying to condense into this brief presentation today, but kind of growing out of my role here at ASDO, working with my hygiene students and in my clinical practice, I've found that as a dental hygienist, I have this really unique opportunity to be able to educate my patients about not only their oral health, but their systemic health while they're there with me. And so kind of thinking about what I could share with all of you is what can we both be doing as we know that oral health is a huge part of systemic health. So what can dental healthcare providers be doing to promote a patient's whole health? And what can our medical healthcare providers be doing to promote our patients' oral health so we can support one another in getting our patients to their healthiest places. So just a couple of our objectives will identify some of these systemic health concerns that can be exacerbated by oral disease. We'll look at what healthcare providers can do to promote systemic health, what those medical providers can do to promote oral health, and then some of the communication techniques we can use to really engage our patients and have them be able to move towards more complete, healthy state. Okay, so as dental healthcare providers, what are we really doing? We're focused on these microbes that are constantly building in the mouth. They create these complex systems that can't be just rinsed away, right? So we have to mechanically go in there and remove them. And as they sit on the teeth, they cause hard tissue diseases in the form of dental caries and soft tissue diseases in the form of gingivitis and eventually a periodontitis. So this bacteria is constantly building up in the mouth, and even just in the process of chewing and talking and brushing our teeth, we are allowing these bacteria to enter the blood system, and they enter our systemic circulation and can cause other really deleterious effects. So we know the literature supports the strong correlation between dental diseases and diabetes. So when a patient has diabetes, they're in an increased risk for periodontal disease or gum disease. And conversely, if their periodontal disease is really out of control, that can make it more challenging for them to control their blood glucose. We know that the bacteria that is associated with the oral cavity has an increased risk for exacerbating heart disease. If these bacteria in our mouth are inhaled into the pulmonary system, it can cause pneumonias or exacerbate that condition. It's associated, these dental plaques are associated with Alzheimer's disease and dementia, obesity, and even for expectant mothers, it can be associated with preterm low birth weight infants. So oral health is definitely a system or an integral part of our systemic health, and we've really got to support it. We also know that these oral diseases can put a burden on our medical healthcare system. So a patient is in pain and they go to the emergency room where they're not really even in, the medical system isn't really in a position to treat these emergent dental conditions. So this is creating, an even greater tax on our already taxed medical system, and it's putting a burden on our economy and on our workforce, right? So in 2017, there were 2.1 million emergency room visits for a dental emergency, and Medicaid paid for approximately 69% of these visits for children and 40% for adults. On average, there are 34 million school hours that are lost annually due to dental emergency care, and over $45 billion are lost annually each year in productivity in the US due to untreated oral disease. So we can see these quantifiable burdens to oral disease, but there's a lot of other burdens of oral disease that we can't really quantify. And that can be contributing to just low self-esteem for an individual. Poor oral health can interfere with our ability to just concentrate at work and in the school. It can interfere with our ability to chew and to articulate well. And it's even been found to interfere with one's ability to apply for and obtain employment. So there are really serious effects of oral disease, and both dental healthcare providers, obviously, and our medical healthcare providers want to be moving our patients towards a more healthy state in our oral cavity. Well, what are some things that dentists or hygienists can do to improve our patients?
What did we send her over there for?
General weakness.
Yeah, weakness, and what else?
She was having.
As dentists, as hygienists, we can promote our patients' health by the few of the tiles that you see here. So we're in no way trying to diagnose anything for our patients, but we can provide screenings and then referrals for our patients. So a blood pressure screening, we conduct or we do blood pressures on every patient, every visit. If we see a trend, that's definitely something we can refer our patients to their PCP for more diagnostics and see if they need to get on something to treat hypertension. Blood glucose screenings, if our patients are diabetics, we're going to maybe take a blood glucose on them, see how well they're being controlled, or maybe our patient hasn't been diagnosed with diabetes, but they've got a really rapidly advancing gum disease. Like we said, there's that two-way street between periodontal disease and elevated blood glucose, right? So we may take that patient's blood glucose there in the office and then maybe potentially make a referral depending on what we find. We are really judicious in the prescription of antibiotics. We know we don't want to contribute to microbial resistance. So we want to be careful in how we prescribe antibiotics. I tell my patients that I'm not a dermatologist and I don't play one on TV, but I can do an intraoral and extraoral exam. I can look for anything that looks abnormal and then recommend that my patient follow up with a dermatologist if we find something. And just reminding a patient that it's a good idea to go see their dermatologist with all the sun exposure that we get here in Arizona. But I've actually had several patients that I've told them, like, I'm not even certain, but if you were my sister or you were my aunt, I would say, get this checked out. And they've come back to me at their next appointment and said, thank you so much for pointing out this little lesion. It was precancerous and we're on, checking to make sure there's no progression. And then we'll spend a little bit more time talking about nutritional counseling here in just a moment, but I think that's definitely within our wheelhouse to talk to our patients about systemic impacts and their oral impacts of what they're eating. And then personally, I think that if we're asking for a social history, then it's our obligation to do screenings of alcohol, tobacco, and other drugs, right? So if we've asked those questions, we should follow up with our patients and educate them and potentially give them a referral to some resources that they may need. So with regards to nutrition, I like to remind my patients that sugar-sweetened beverages are the highest source of sugar in the Western diet. If we drink just one Coke, 8-ounce can of Coke a day for a year, we've consumed over 100 pounds of sugar just in that soda alone. The average American consumes around 150 pounds of sugar a year. That's really like astounding information, but it's important that we educate our patients about that and really encourage them to make some better choices. As we said, we're doing blood glucose screenings when indicated. And then as a hygienist, I'm manipulating soft tissue, right? So I can encourage my patients on what foods are going to be anti-inflammatory and promote good soft tissue healing after I've done a cleaning or done a deeper cleaning post-surgery, right? And then really advising them like what foods are considered pro-inflammatory, trans fats, fried foods. These are things that we'd want to avoid in an effort to speed healing and the healing process. Okay. So just a couple of things about social history. I know that this is something that I've had to work on as a hygienist to learn more about, to be able to educate my patients and feel comfortable talking to them about tobacco cessation and their alcohol consumption, and then how that ties into their oral cancer risk. So this is a graphic that I like to use. You can ask your patient, a lot of times we ask our patients what their alcohol consumption looks like, and then kind of discussing with them, like, are you considered at low risk? For a man, that's no more than 4 drinks in a day or 14 drinks in a week, and a woman 3 drinks in a day and no more than 7 drinks in the week. So a lot of patients do fall outside of this, and that's kind of alarming for them, right? That they didn't realize they would be considered an at-risk drinker. Also, something to note is this number decreases with regards to medications that we're on. So there's a lot of patients that are on medications that interact with alcohol, and we'd really want to reduce even this amount. Okay, and then I definitely want to talk to my patients about their tobacco use. So if my patient uses tobacco, I'm picking up a hand mirror and I'm showing them some sort of change in their soft tissue to kind of help them understand their risk. Is it just enlarged minor salivary glands on their palate? I had a patient a few years ago that was a young man who smoked, who I found a mass on his uvula. I pointed that out to him, and it scared him enough that he stopped using his tobacco products. So that was definitely something that I didn't mean to use fear-mongering, but just, educating him about his risk. So definitely something we want to do, maybe even pointing out to them how their tobacco use could be contributing towards their advancement of a gum disease. And then a tool that I like to use to kind of open up the conversation and see where they are in regards to making a change or changing a health behavior. This can be used for anything, but I'm just giving it in the context of tobacco use, a readiness ruler. So asking them on a scale of 1 to 10, how willing or how open are you to reducing your tobacco use? And if the patient gives me a low number like 3, I'll ask them, well, that's good. So what makes you pick a 3 versus a 1 or a 2, right? And if they give me a higher number, like a 7 or an 8, I'll say, well, what would it take to get you to a 10? So we're drawing out of them their own reasons, their own motivations, and having them articulate that to us, which can be a powerful tool in moving them incrementally towards a change in their behavior. So we've talked about things that dental healthcare providers can do to promote overall health. And let's just talk about some of the things that a medical professional can do to promote a patient's oral health. So we want to be able to recognize decay and gum disease, guide a patient towards preventative services, and provide them with an oral cancer screening. And then just encourage them in good oral hygiene practices. So dental caries are going to be present in this breakdown of that outer surface of the tooth, the enamel. You'll see maybe a softening of the enamel, a breakdown of that, maybe an open lesion or a dark area on the tooth. These would all be good reasons to advise that patient to go see a dental healthcare professional. And gum disease is kind of on a continuum, right? It can just be some inflammation of the gums. Maybe you're just seeing some slight ulceration or redness around the margins of the teeth. But it also can be like this enlargement of the gingiva where we're seeing it's really big and bulbous tissue. It could be to a point where the bone and the ligament that support the teeth is so broken down that the gums are pulling away from the tooth, and you're seeing this elongation of the tooth or an exposure of the root surface. So those would all be reasons to really encourage this patient to see their dental healthcare provider. And then oral cancer screenings, I think, are so important. When we consider health disparities, we have to consider, and dental health disparities, we have to consider oral cancer. So in the last 50 years, we've had advancements in surgical techniques and radiation and chemotherapy, but oral cancer is actually still has a really poor 5-year prognosis at around 50 to 55%. We know that men are most at-risk populations. And sadly, even in the last 10 years, we haven't seen much of a decline in mortality rates for these groups. So white men have had a slightly better prognosis, but African-American men have actually had an even worsening in mortality rates from oral cancer. So this is something that we really want to be aware of for our patients. We also know that the combination of alcohol and tobacco together increases our patients' risk of getting oral cancer by 30 times. That's huge, right? So we need to educate our patients about that. So if you think about that alcohol and tobacco in the patient's mouth, these carcinogens pool on the floor of the mouth. And so these are our most common areas, our highest risk areas for oral cancer. So we can look at the floor of the mouth and the lateral borders of the tongue to really ensure that the patient doesn't have any changes in that tissue that we would want to get them looked at for, or to start treatment for the patient. Some of the other things that we should consider is, when did this start, right? What's the onset? How long has it been around? I think we mentioned before, we have this really rich blood supply to our mouth, which is wonderful, and it can usually help things heal quickly, right? So if something doesn't resolve within the oral cavity within 2 weeks, it's probably worth getting a follow-up for. That's something that should be looked into further. Definitely, if the patient has symptoms of pain or sensitivity, if that area is bleeding, those are all reasons to do follow-up for the patient for a lesion that we're seeing. And we want to see, is there symmetry in this lesion? Do you see something on the exact same side, or there's dual appearance, right, on either side of the mouth? Maybe we're just looking at an anatomical structure, but these are things that we want to consider in our evaluation. So here's just an example of an oral cancer screening. I would say really just taking your time, not being afraid to really pull out the tissues, look at the underside of the lip, look at where the mucosa of the mouth and the gingiva or gums meet, stretch out that cheek, look down into the vestibular area, or that little groove between the cheek and the gum, looking at the roof of the mouth, back into the throat, having the patient say ah, or we can depress their tongue to be able to look back into that tonsillar area. And then G and H are pictures of those really high risk areas: the floor of the mouth, the ventral surface of the tongue, and the lateral borders of the tongue. So for my patients that have an increased risk for oral cancer, I'm teaching them how to conduct their own oral cancer screening, and then telling them if they see anything in their mouth that isn't resolved within 2 weeks, make an appointment with us. And we can all be doing this. We can all be educating our patients about that. Okay, so here are just a couple of examples of some suspicious lesions that we may find in a patient's mouth. You can see that there's like mixed red and white appearances, that they're in these high risk areas, right? We can't attribute these conditions just to trauma, or where the patient maybe just bit their cheek or bit their lip, right? But these are maybe even have some sort of symptom that's associated with them. So these are all lesions that would warrant a follow-up with the patient. Okay. And then some other things that we can be doing are just encouraging our patients. I actually felt pretty appreciative that although I'm a dental hygienist, I had the last annual exam I had, my healthcare provider looked in my mouth and then asked me what I was doing for my oral hygiene routine. I don't think she knew that I was a hygienist, but that's good. It's good that you're asking those questions. So encouraging a patient to brush 2 times a day for 2 minutes, to floss routinely, to use an antiseptic mouth rinse, to reduce the microbial load within the oral cavity, and then just really encouraging our patients to see the dentist at least once a year. And I don't think it's a bad idea to review brushing technique with them, right? Like explaining to them that the bacteria in our mouths really likes to accumulate in this little space or sulcus between where our gums and our teeth meet. So in order to really cleanse the oral cavity, we're directing our bristles up towards where our gums and our teeth meet, or down towards where our gums and our teeth meet. We do this little vibrating stroke to gather that bacteria and sweep it out of that sulcus. And so just reviewing technique with a patient would take only a moment, and something to just encourage them in good practices. So we've talked about we can both be working to address a patient's social history. We can tackle health inequities in our practice by conducting oral cancer screenings, and by also addressing our own biases and checking for our own blind spots in our practice and our evaluation of our patients. And then I also think it's important to remind ourselves that we want to provide evidence-based information. It's not anecdotal, but we have practices and recommendations that are grounded in the research. So with that being said, what are some ways that we can strengthen our communication with our patients? I think so many of the things that we can do is less talking, which I've been doing a lot of today, and more listening. So the literature suggests that the average doctor interrupts their patient within the first 30 seconds of an appointment. So we can actually have a more engaged and more efficient appointment if we don't interrupt our patient. We listen to them. They get to fully express what their concerns are, what their needs are for this appointment, and then work together to prioritize those needs within the appointment time that we have. So we want to not interrupt our patients and listen to them fully. Then some of the nonverbals that we can also do are not turning our back to our patients, having appropriate eye contact with them, using our body language to lean forward, maybe to nod our head, to let them know that we respect them, that we are engaged in conversation with them. I try to make sure my patients are in a chair, right, and laying back. So I try not to have conversations with them where I'm over top of them, right, but I've seated them up and maybe even put their chair a little bit higher than mine, just as these nonverbals that I'm respecting them and they don't feel like they're being literally spoken down to. And then I think it's a great idea to ask our patients for permission to discuss things in their medical history. This is just giving them a little form of autonomy, right? Letting them feel like they have some control of what's going on in the conversation. And we want to be moving our conversation away from a sympathetic response to a more empathetic response. And I think the crux of this is that we don't always have to say something, right? We don't always have to provide a solution or answers, right? But just listen to our patients, let them know that they are heard and they are understood. And a lot of that can be done in our nonverbal communication. So I have a quick video by Brené Brown kind of discussing the importance of empathy in our communication with our patients that I'll share now.
So what is empathy, and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions very diverse professions where empathy is relevant and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, I'm down. I know what it's like down here and you're not alone. Sympathy is, ooh, it's bad, no, you want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with at least. And we do it all the time, because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So I had a miscarriage. Oh, at least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now. I'm just so glad you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
Okay. So with that in mind, just a couple more things about how we can really communicate with our patients. And many of you are probably familiar with motivational interviewing, but this is a way that we can educate our patients, or not really educate, but help them move towards a behavior change by eliciting from them what their own intrinsic motivations may be for a change in their behavior. So I'm already showing my weakness as a healthcare provider, because I have solutions, I have answers for you, I have recommendations, right? But kind of quieting that and being able to speak to a patient where they tell you why it is that they want to see a change in their behavior. And so there's an acronym that we can use in this technique that's called ORS. And that first letter O stands for open-ended questions. So inviting the patient's perspective, asking them about something that we see that's concerning in their medical history. Maybe affirming what their barriers are to care. They start telling you why they're not ready to make a change, or what is concerning them about this condition, and expressing that, wow, you've been through a lot. It sounds like, this is a big deal, or just really showing them that you can appreciate where they're coming from. Reflective listening, we're making sure we understand what they're saying, restating, using their own words to kind of reiterate what they've told us. I think this is a time too where we can create discrepancy for a patient. Some motivational interviewing literature talks about a decision balance sheet. So we don't have to actually write that out, but we are talking to our patients about how on one hand, you'd like to see this change in your health, or you have this health goal, but on the other hand, smoking is really important to you, right? So I'm just giving an example, right? So kind of helping them see where their behavior, their current behavior is in opposition to a health goal that they may have. And it also, that R can also stand for rolling with resistance. So if a patient tells you that they're not interested in behavior change, we are not going to push that, right? We're going to let that be and respect that they're not really in a position to move forward with a behavior change. And summaries are where we can kind of just recap what we've talked about and maybe ask them for permission. Is this something that we can talk about in the future? So something that was a little bit encouraging to me, some literature that I came across talked about how a patient is more likely to make a change in their behavior if they have had this conversation multiple times, if you as a healthcare provider have brought this up more than one time with them. And they're also more likely to make that behavior change whenever there's been a variety of healthcare providers that have brought this to their attention. So I think about that, like, I may not be the one to help this patient actually move to an action phase, right? But I could be laying the groundwork. I'm sowing some seeds for somebody else, right? So this patient saw their PCP last Tuesday and they talked to them about this change in their behavior or maybe changing something in their diet. And then, gosh darn it, now my hygienist is talking to me about this. Maybe I should consider cutting back on these sugar sweetened beverages that I'm consuming. I think that this is kind of reiterating that we're all playing this role together to gently nudge our patients towards some healthy behaviors that are going to be supportive of their oral and systemic well-being. So we're probably all familiar with the trans-theoretical model or the stages of change. But what I really want to say from this is we can't really try to push our patients too far along too rapidly, right? So these are changes, they're incremental changes that we can make. And so we want to move our patients gently towards a change in their behavior by just meeting them where they are and then just maybe giving them a slight boost to the next stage of change. Sorry, there's a little bit of background information or noise here. Okay, so I now have just a couple of scenarios that I'd love to invite your perspective on, what you feel like we could do to promote these patients' health and well-being. So I have, so if you want to jump in either on the microphone or in the chat, that would be great. But I've got a 59-year-old female that's coming in for a comprehensive exam. She has type 2 diabetes. Her HbA1c is 8.4. She's taking glipizide to control that. But her blood glucose today fasting is 204. You see that she has advanced periodontitis, multiple dental caries, and she's told you that she's made this great transition and she's trying to lose weight using a shake and juice diet. So do we have any concerns and how can we educate this patient?
Well, I can state something. She definitely needs a referral to a dietitian.
Yeah.
And possibly could use some discussion about advanced perio and how that's linked to diabetes, lack of control of diabetes. She's got a high HbA1c. And I would talk to her about, I'd probably say it's great that she's tried to make some changes in her diet program and ask her if she's talked to a physician about that, only because she may have a high sugar intake when she's not eating the orange, the fruit and the maybe vegetables raw rather than in a liquid format.
She's not getting the fiber, right? Yeah, I
probably
see this.
High sugar.
Yeah, there's lots of people jumping in saying high sugar in these shake and juice diets, and you're absolutely right. I actually had a patient this is based off of, and she was just totally astounded that, yes, that her dental condition was in such poor shape, and she's telling me like, oh, I'm working really hard on this, but she wasn't getting the right resources, right? She's on the wrong kind of diet for her systemic health, and it's negatively impacting her oral health as well. So she needs to yes, work with a nutritionist or a nutrition center. Thank you. So many good comments here. Yeah, and then talking to her about this interaction, right, between the periodontal disease and the high sugar intake. Awesome. Thank you so much. And thanks, Kim, for jumping in here too. Okay, so I'll just do one more scenario with us where we have a patient that's presenting with hypertension and insomnia. She's on lisinopril and luminol, and her social history is pretty insignificant, except for the fact that she has 2 to 3 glasses of bourbon at night, help her go to sleep. So do we have any concerns for this patient? So this combination, right, of our alcohol with the medication could be really detrimental for her. So I like to share with a patient what is considered a standard drink. And when she tells me she's having a couple of glasses, right, yes, her blood pressure is elevated as well for her hypertensive state, right? So these are all things that could be great. Thank you so much for talking about how alcohol can contribute to hypertension as well. So it sounds like we all have good information here that we can be sharing with our patients, and just helping guide them to maybe that we're in making good efforts, but they're a little bit misdirected. So helping them understand how all of these things are interconnected. Okay, so I'll just finish by saying integrative practice is really our future. I see us needing to have nutritionists, medical healthcare providers, and dental healthcare providers all together, increasing our ability to meet our patients in areas that are hard, or access to, increasing access to care, and being able to work comprehensively to treat our patients and bring them to a state of wellness. So I have my references listed here, and I'd love to invite any questions that you may have.
Yeah, feel free. I mean, I'm fine with people unmuting themselves and asking the questions verbally too, as long as you are, Victoria. But you can also put them in the chat and I can relay those. Here's one. How do you cause a change in lifestyle without sounding judgmental and or making the patient defensive?
It's a great question. I think that creating a trusting relationship first, right? Like, I think about one of the things that I talk to my patients a lot about is a change in, like, reducing their use of tobacco. And so I don't ever start my appointment with a patient that I'm going to talk to them about that, but I'm going to have a little bit of time in that appointment, have built some rapport with them, tell them what it is that I'm concerned about with their oral health, and then just kind of put that back to them, like, is this something that you're concerned about? So I think, when we demonstrate true empathy and true concern for a patient, that's not something that's going to come across as judgmental. I hope that answers that question, but I also don't want to just jump into it as the first thing, because I've done that in my naivety, and it doesn't go over well. Yeah, thank you so much.
Any other questions out there?
Oh, I was going to ask a question. So, do wearing the mask like increase risk of like gingivitis or other, conditions to the mouth, especially when you're maybe taking medications, or,
Right.
Using alcohol or tobacco or all three, or?
Yeah, I think that, like, it seems like it's an anecdotal thing that we say, like, I feel dry, I feel, like and I would say personally, I don't drink as much throughout the day because I'm wearing a mask all day and I'm wearing an N95, and it's hard to take all of that off. But the actual wearing the mask being contributor to like an inflamed perios or inflamed gingiva, not necessarily, right? But maybe contributory to a dry mouth condition that then, we can have some buildup of plaque or just gingival inflammation or irritation. So I would say, recommending for a patient, like, go ahead and, be rinsing your mouth or hydrating your mouth with water versus anything else. But that's a great question. Thank you.
Any other questions? Here's just a comment. Excellent presentation. I love the emphasis on empathy and also on the great stats. 150 pounds of sugar annually. Yeah, it's kind of an eye opener. Yeah.
It is. And if that's the only thing we're consuming is the sugar, we're already at, or just the 8-ounce can of soda, we're already over 100 pounds. So it is kind of extreme.
Yeah.
So thank you so much, everyone, for joining.
Yeah. Thank you so much, Victoria. It was very insightful and yeah, learned a lot on it. So I do appreciate it. And everyone else, thanks for attending. And again, make sure you give yourself credit for today's Still Healthy seminar. 41 days until that deadline. So that's going to approach really quickly. And then for those that attended, we are going to give away a little door prize, probably a Bluetooth speaker. So one on each campus, Arizona, Missouri, or even if you're remote, you're entered in. So be looking out for on your email to see if you're a winner for that. You will have to accept the taxes on that, but yeah. So anyways, thank you again, Victoria. It was very good. We do appreciate it. And again, this will be on our Still Healthy YouTube and Google sites. So if you weren't able to attend the whole thing or you just want a refresher, you can watch it back later. So with that, we will end it here. I hope everybody has a good rest of the day. Thank you guys so much.